Hi, I'm really pleased to be here to speak with you all about constraint therapy for children with hemiplegic cerebral palsy, what you need to know from the brain to the clinic. In terms of disclosures, I have peer-reviewed research funding from CIHR, Child Bright Kids Brain Health Network, and OBI. Otherwise, I have no conflicts of interest in relation to this presentation. So objectives. I'll provide a clinical definition of constraint-induced movement therapy. I'm going to spend a chunk of time highlighting the research on underlying neural mechanisms of action of constraint in hemiplegic cerebral palsy. And then I'll highlight some practical aspects of providing constraint within a developmental framework. So how you can differentiate things for babies, preschoolers, and school-age children. So the flow of the talk. I'm going to introduce a concept, translational neuroscience networks. I'm going to then present some clinical findings about hemiplegic cerebral palsy from a translational neuroscience network called CPNet. I'll then transition into presenting research on the neural mechanisms of action of constraint. I'm going to highlight a knowledge implementation science baby constraint project. And then I'll finish with some practical aspects of constraint. And throughout the talk, I'm going to integrate a case study. So what is a translational neuroscience network? It really is a group of researchers coming together that spans preclinical, basic translational research and clinical research with clinical services and engaging stakeholders. And the concept of the network is really trying to bridge the gap. We know there's a big gap between what's happening at a basic science and translational basic science level that is slow to trickle into clinical practice. And by forming these networks, we can create dialogue, set some common goals, and hopefully move research into clinical practice faster. So in terms of a neuroscience network, it really spans a variety of research activities. So there can be the basic translational research, clinical research on neural mechanisms of action. There can be clinical research on effectiveness. There can be knowledge implementation science research. So it's really a spectrum of research activities that are held together by common goals. And another important element is really having active stakeholder engagement so that the goals that are being set are actually relevant to the stakeholders. So CPNet is one of these translational neuroscience network, and I've been privileged to be the scientific lead of CPNet over the last several years. As you can see, it's a group of investigators that are based in Ontario. It's funded by the Ontario Brain Institute, and we have many academic institution partners, as well as partners for children's rehab centers, for example, Grandview, Erin Oak, Hull and Bloorview. So here's a visual for CPNet, and I just put this up so that you can see the span of research that can be encompassed within translational neuroscience networks. So here's research focused on neural mechanisms of brain repair, research focused on genomics and epigenetics of cerebral palsy. And then there's some clinical effectiveness research, looking at a clinical database, looking at how to promote wellness, doing research in neurotechnology and therapeutics. And then there's knowledge mobilization and stakeholder engagement. So part of CPNet, a core part of CPNet, is the clinical database. And currently we have 900 children in the database. And we collect information across a variety of platforms. So we collect information in a standardized way on clinical risk factors for cerebral palsy. We collect their neuroimaging, and we do a standardized categorization of the imaging. We collect saliva with the child and the parents, and then extract the DNA. And we can do whole exome or genome sequencing on that saliva specimen. We collect standardized information on their child's neurodevelopmental status. And then we're also very interested in psychosocial and participation markers and family health markers. So we collect that information as well. So within that clinical database, we started with a database that was focused on children with hemiplegic cerebral palsy. And children were recruited into the study between the ages of 2 to 18 years of age. They needed to have a confirmed diagnosis of hemiplegic CP and be residing in Ontario. And so within our HemiNet data, we had approximately 320 children in the clinical database. Going back to our translational aspects, we worked with scientists that were running basic science labs and integrated a rodent model of cerebral palsy where they created an asymmetric injury. This is the MRI of the rodent, and you can see the large asymmetric injury here. And then you can see the clinical phenotype here. The rodent is dragging the hemiplegic leg. So here's your case study. You're seeing John at 9 months of age for a neurology consultation due to an early hand preference. Parents report that he's crawling well, playing with toys, more with his left hand than his right. They're not concerned because many people in their family are left-handed. You do a neurodevelopmental screen, and you notice that the child grabs the toy with a pincer grasp on the left hand and a palmar grasp with his right hand. So let's look at a video. This is a slightly older child, but there's the beautiful pincer grasp and release. And then on the other side, you see palmar grasp. So you see clear asymmetry. So you order the following test. You get an MRI, and you see that this particular child has had a large MCA infarction. So let's move to the clinical findings of hemiplegic CP that we've derived from CPNet. So one of the things that we looked at was intersecting our neurodevelopmental platform with the neuroradiology platform. And we looked at neurodevelopmental outcomes of children with hemiplegic cerebral palsy who'd had middle cerebral artery infarcts compared to periventricular venous infarctions. So one of the interesting things that we found on the neuroimaging patterns in our clinical database is we weren't surprised to see a large component of close to 40% of children who had an MCA arterial infarction. What was surprising to us was that there was close to an equal number of children who had asymmetric periventricular injury patterns explaining their hemiplegic cerebral palsy. And then within this, we had a large proportion, the striped line here, that had a periventricular venous infarction. So from a vascular injury pattern, the most common vascular injury pattern was the MCA, but the periventricular venous infarction was the second most common vascular pattern. So just this is the MRI that shows the MCA, and the size of the MCA infarcts can vary depending on which branch is involved. And then this is a diagram explaining the mechanism of action behind the periventricular venous infarction. And this diagram is courtesy of Dr. Adam Curtin, a pediatric neurologist, one of our colleagues from Calgary, Alberta. And it explains the etiology behind the periventricular venous infarction in a preterm brain. This can happen also in utero or in the prenatal period. If you get a germinal matrix bleed, this creates some venous congestion. And then you get a backflow of sluggish blood not exiting the vein. And this can lead to a venous infarct, a stroke. And then this is a very typical classic MRI pattern of an individual who's had a periventricular venous infarct. So you can see asymmetry, but it's in a different location than the MCA injury, which sits out in this side. Neuroradiologists are becoming increasingly familiar with diagnosing periventricular venous infarcts, but it's something that has been an evolving skill over the last several years. So what did we find when we looked at the neurodevelopmental outcome? Here we have children with MCA infarcts represented in blue and periventricular infarctions represented in green. And what we found was that the hand function was better in children with periventricular venous infarcts compared to children with MCA. And then hand usage was also better for children with periventricular venous infarcts compared to children with MCA injuries. We also looked at sensory information, and we found again that children who'd had the periventricular venous infarcts had higher sensory function across proprioception, two-point discrimination, light touch, and pinprick. So I mentioned at the very beginning that stakeholders are important, and we formed a stakeholder group right at the beginning of CPNet. And one of the things that we heard from our stakeholder group was that they really were concerned that their diagnosis for their child of hemiplegic cerebral palsy was a late diagnosis. So it was very important to them that the diagnosis be made early, and they received a connection to early intervention services. So hand preference starts to develop at 18 to 24 months of age. So a red flag for clinicians to be aware of is any strong hand preference prior to 12 months of age. So just referring back to our case study of John, who presented with the hand preference at 9 months. The other thing that I want to highlight is that under 18 months, children's movement patterns are very symmetrical. So if you're observing the child moving and you're seeing a lot of asymmetry of motor movements or asymmetry of motor skills, so that difference between the pincer grasp on one side and the palmar grasp on the other side, that really should create a red flag for you and highlight that there is something going on with this child. So this is a fabulous website if you're involved in teaching any students about how to do a neurologic examination. It's open and free. So this is just a little clip of a typically developing child at 6 months of age. Let's see if I can get the video to go. There we go. And you can see nice symmetry. The head is in a central midline position and definitely interested in trying to grab the blocks. We can see a radial approach and of course, right into the mouth. So we've got a second block here to see if we can get the child to grab, and we're going to look to see how the child grabs this green block. And there we go. And we've got really nice symmetric movement patterns. So back to our case study. You've made a diagnosis of unilateral spastic right hemiplegic cerebral palsy, and the parents look at you and say, okay, well, what treatments are you going to recommend? So one of the common treatments that we use is modified constraint therapy for children with hemiplegic cerebral palsy. And I'm now going to move into our deep dive into exploring what are some of the underlying neural mechanisms of action of constraint. So what is constraint? It's a treatment to improve motor function in the affected upper limb. And in children with hemiplegic CP, in constraint therapy, the unaffected limb is restrained in some way, and then it's partnered with the child undergoing intensive structured therapy, play-based therapy, focusing on engaging the affected upper limb. So do we have evidence for constraint? Does it work? This is a diagram from Iona Novak's publication in 2013, which was a systematic review of interventions for children with cerebral palsy. What was the state of the evidence? And there's these cool bubble diagrams here. And if the bubble is up high in green, it means that there's good quality evidence for the treatment. If it's down low and is red, it means there's not, and you should not do it. And then there's, of course, the in-between where we need more information. The other thing about the diagram is that the size of the bubble represents how much evidence there is. So in 2013, if we look at the green bubble for CIMT, we see it's quite large, one of our largest bodies of evidence that constraint-induced movement therapy can improve motor function and activities for children with hemiplegic cerebral palsy. Now, this is an update on the evidence in 2019. The same bubble diagram, and again, you can see constraint is still in the green and has quite a large body of evidence. I'm smiling here because it's great to see the field moving forward. So you see lots more bubbles, and that's certainly a positive reflection that people internationally are doing research to evolve our evidence base for treatments for cerebral palsy. So here's just a brief video of a child who's receiving constraint. So her non-hemiplegic hand is just in that removable splint. And then she's been encouraged to do play-based activities with her hemiplegic hand. And you can see that this is hard work for her, but it's play-based and provides an opportunity to remind her brain to use her hand and practice with her hand, and a motor skill that she is able to accomplish. I want to highlight the concept of developmental disregard for children with hemiplegic cerebral palsy. So not only do they have difficulty with fine motor control, selective motor control of their hemiplegic hand, they tend to ignore their hemiplegic hand. They become quite good at using their non-hemiplegic hand. And so another way that constraint can work is reminding the person to use their hand. So this is a school-age boy who's receiving constraint, and this is one of the outcomes on the assisting hand assessment. And the task is to grab the cymbals and bang them together. So this is pre-constraint. And you can see that he's ignoring his hemiplegic hand. He's having difficulty figuring out how to grasp the cymbal. And then this is the same task post-constraint. And you can see that there's less disregard, and he's able to do that activity in a bimanual manner. So We have good evidence that constraint can help to improve hand function. And what we wanted to do was to understand the underlying neural mechanisms behind how constraint may be working. So I'm just going to give you a little bit of background here. So this slide is just a slide of the motor cortex, the cortical spinal area, and tracts. And the message I want you to take from this slide is that our control of our movements is contralateral. So typically, the right side of our brain controls the left side of our body. The left side of our brain controls the right side of our body. And there's this crossover that occurs to facilitate this contralateral control. These are some of the tools that we can do in clinical research to understand what's happening at the brain level. So here's in the black and white are the MRIs. And then if you look at the yellow dots, this represents a functional MRI. So what the functional MRI does is it looks at a ratio of oxygenated areas of the brain versus non-oxygenated areas during a motor task. And the MRI is sensitive enough to highlight which areas are active. Now, this little symbol represents transcranial magnetic stimulation. And you can put a stimulator over the motor cortex and stimulate the motor evoked potential that you can record. And this is in an individual who's had an MCA infarct. And here a stimulation pattern shows contralateral control. But on the opposite side, when the transcranial magnetic stimulation is stimulating the ipsilateral area, you can see that there is, the contralateral control, but there's also maintained ipsilateral patterns for the non-involved hemisphere. Now, another tool that we can use is MEG. And MEG is an interesting tool. So it represents a power vector that you can detect in a region of interest. And so it can give you information on activation patterns overlaid on the structural MRI, as you can see here. But then what it does is it breaks down the information to time 0 in milliseconds. So prior to time 0, you can have the motor planning represented here in red. And after time 0, you can have the sensory proprioceptive response. So it's starting to give you differential information in the motor and the sensory areas. Now, the other background piece of information I just wanted to highlight is just, how the motor cortex is organized. So we have our primary motor cortex here. We have our primary somatosensory cortex situated right behind it. But there are supplementary motor areas as well. Here's the supplementary motor cortex that sits just in front of the primary motor cortex. And then here's the premotor cortex that sits in front of the M1. So here is a pattern that can be seen in individuals with hemiplegic cerebral palsy who've had an MCA infarct or who have had a hemispherectomy, say for seizure management. And so this is our individual who has the MCA infarct. It's just pictured here in terms of the area. And then here is the corresponding functional MRI. So the individuals in the MRI unit, they're doing a task where they're moving their hemiplegic hand. And this is the side of the brain that is injured. And you can see for this particular person that they have shifted the control of their hemiplegic hand from contralateral to ipsilateral. And then if we look at which areas they've shifted to, here we see a beautiful picture of the M1 and then the S1 sitting right behind it. They've shifted to the supplementary motor area and the premotor area rather than shifting to the M1. So what other background do I want to share quickly before we start to go through the research? This is a really elegant body of work led by Martin Stubb in Europe. And this is a complicated slide, but I'll just orient you briefly. So a score of 1 means you're using your hand well, and a score of 4 means you're really having trouble using your hemiplegic hand. You're not sending a clear message through. And then the circles represent ipsilateral, which is an open circle, and contralateral control, the black is ipsilateral, the white is contralateral. And don't worry so much about the lesion type here. The message that I want you to take from this particular slide is that there's some early evidence that individuals who can maintain contralateral control have better hand function compared to individuals who are moving towards ipsilateral control of their hand. And then finally, we have some information from our adult colleagues, clinicians, who are working with individuals who have acquired stroke. And this particular body of work started to appear in the literature in the mid-2000s, and they were looking at non-invasive brain stimulation. And one of the interesting things that they discovered is when you had a stroke, one of the ways that the brain reacted to that is that the hemisphere that was not injured suppressed the hemisphere that was injured. There was this interhemispheric inhibition that in this particular case, non-invasive brain stimulation could release and rebalance the activation across the hemispheres. So with that background information, what are some of the potential underlying neural mechanisms of constraint in hemiplegic cerebral palsy? So this is some early research that we did with functional MRIs in children pre and post constraint therapy. And one of the things that we did was we measured laterality indices. And this is the ratio of the contralateral versus ipsilateral control. And we would be predominantly contralaterally controlled. And if we were to do a functional MRI, our laterality indices would be quite high. They'd be positive and they'd be at 0.8, 0.9. And then if it's negative, what it represents is that there's more ipsilateral than contralateral control. So one of the things that we were able to identify is that pre-therapy, children had this predominant ipsilateral control. We had negative laterality indices, and that after constraint, we were able to shift activity back into the contralateral motor cortex, and the laterality index became positive, and that we still saw this signal 6 months post-therapy. So interesting. Constraint therapy can shift from activity happening in the ipsilateral motor cortex back into the contralateral motor cortex. And that may be a mechanism for underlying brain recovery and improved hand function. Now, this was our early work looking at MEG. So I'm going to just orient you to the slide here. Here's our region of interest in the injured motor area. And we had two baselines, and we saw very similar power messages, 2.8, 2.7. And after constraint therapy, we had an increase in signal in the contralateral area. So that was complementary to the functional MRI work that we completed. But then if we look at the time breakdown, the blue and the black are the two baselines, and the red is the signal after constraint therapy. And one of the interesting things that we found is we saw very little difference in the motor messaging pre. Our signals seem to be in the sensory processing post. So this suggested to us that the sensory element of response to constraint may be part of the story, part of the neuromechanism of action. And we continue to investigate this and have recently published this paper in Pediatric Neurology just earlier this year. And so what we found in children after constraint, I'll just orient you. So here we have the detailed somatosensory evoked potential that we're able to produce following MEG evaluation. And this is in the unaffected hemisphere. The blue represents baseline, the red represents post-constraint therapy. And we can see a very typical somatosensory evoked potential with a typical wave pattern in the unaffected hemisphere. And one of the interesting things is that there was very little change after constraint. So that's reassuring. We don't want to be negatively impacting the non-hemiplegic hand. But of particular interest is the change that we saw in the somatosensory evoked potential in the affected hemisphere. And what we see is we start to see a normalization of the somatosensory evoked potential following constraint. And statistically, we're able to best see it at the P100 wave mark. Now, so we've got some information that we've got shifting of activity into the contralateral motor cortex. I've just shown you some evidence for improved somatosensory processing in the affected S1. We were interested in exploring this concept of hemispheric inhibition and whether constraint could rebalance the hemispheric activity. And we were able to get at this particular question through looking at resting state images. So there are several resting state networks that exist in our brain, but the one that we were particularly interested in for this work was the sensory motor resting state network. We all have one, and our resting state networks are very balanced. So here you can see a typical resting state network. The right side of the brain is communicating with the left side of the brain. It's very symmetrical. So if we take this concept of a laterality index, and I presented that before for a functional MRI, where our laterality index could go from -1 to +1, for a resting state network, where we have a balance between the hemispheres, our typical laterality index would be 0. We're having equal activation of both hemispheres. And so when you do that ratio, it becomes 0. So what we found in individuals with hemiplegic cerebral palsy is there is definite asymmetry of that resting state sensory motor network. So here you have an example of an individual, and you see there's activity in the non-injured side over here, but much less activity in the injured hemisphere. And then post-constraint, we can start to see a rebalancing of the hemispheric activation. So there's more activity happening. There's less interhemispheric inhibition following constraint. And this is our group data. And again, our ideal resting state network is 0. We had a control group who didn't receive constraint. There was very little change in their resting state network, which was negative. And then in the group that received constraint, we see a movement, a positive movement towards 0 in the case group. So I started the talk by talking about translational neuroscience networks, and this is definitely something that we're quite excited about in CPNet, to have our basic scientists contributing to common goals in this particular case of investigating constraint mechanisms of action. And one of the things that the basic science group needed to do is figure out how to mimic constraint therapy. And their early trials were with little casts on the rodents, but the mama rodents quickly took the casts off. And so eventually the group started to constrain the limb with Botox injections. And what they found was they had functional recovery tests where they looked at gait analysis. And there's also a cylinder test where the rodent tries to move up the cylinder. And they found functional recovery post-constraint. They were able to do MRI and found restoration of structural integrity, particularly through the corpus callosum, so that linking between the hemispheres. And then they found that constraint led to a recruitment of endogenous oligodendrocytes in the corpus callosum. And they're represented in the pictures below as the bright purple. So these are the new oligodendrocytes. And there's a lot going on in this particular slide, but I just want you to focus on the yellow bar here. So this is the group of rodents that didn't receive the constraint. And this is the group that did receive the constraint. And we see higher counts of endogenous oligodendrocytes in the rodent model that received the constraint therapy. So, isn't it exciting to have an intervention where we can actually measure a signal at the brain level? And we certainly wish that we could do that in many of our pediatric rehabilitation treatments. So we're excited that we're starting to get this signal at the brain. So what have we shown in terms of central mechanisms of action? Enhanced activity and processing in the contralateral somatosensory cortex, enhanced activity in the motor contralateral cortex, and then a rebalancing of hemispheric activation. And then we're also excited to be exploring a neural plastic response with support for enhanced neurogenesis post-CIMT. So I'm now going to talk briefly about our Knowledge Implementation Science Baby CIMT project. I'm going to bring you back
Sorry, I couldn't quite hear you. Could you?
I'm going to bring you back to our case study, clinical diagnosis of right hemiplegic CP, and the parents have asked you what treatment you would recommend. So you really want to recommend baby constraint. However, there's no baby constraint programs in your area. What can you do? So we've been really excited and having a lot of fun doing a knowledge implementation science project focused on trying to promote baby constraint. So in Canada, the average age of cerebral palsy diagnosis is late. Currently, we have it sitting at close to 19 months. And the other thing to highlight is that hemiplegic CP is one of our commonest forms of cerebral palsy. Now, this diagnosis of 19 months represents a late diagnosis. We now have international clinical practice guidelines that exist that outline that children can be identified as early as 5 months of age, particularly if they're in the high-risk infant group and followed in neonatal follow-up clinics. And we've got evidence that baby constraint is effective, but not readily available. So what strategies did we decide to embark on trying to move baby constraint forward in our Ontario, province of Ontario? So we identified 3 strategies. One, to support the early identification of hemiplegic cerebral palsy. And this strategy was linked to introducing the Hammersmith infant neurologic examination into neonatal follow-up clinics early, before 3 months of age. It's a very effective tool for picking up hemiplegic cerebral palsy, in addition to all types of cerebral palsy, because it highlights an asymmetry score that puts that child at risk for hemiplegic cerebral palsy, and you can detect it quite early. We then, step 2, identified strategies to facilitate early referrals for infants with or at high risk for hemiplegic cerebral palsy through the neonatal follow-up by linking neonatal follow-up to baby constraint programs. And 3, we facilitated support for building baby CIMT early intervention programs. And the mechanism for this particular action was to work in partnership with our children's rehabilitation centers. We had 5 sites that agreed to be involved, and we identified a baby constraint OT lead at each of these 5 sites. So this is just a visual teaching neonatal follow-up programs in the administration of the Hammersmith, an absolutely fabulous tool. Facilitating the early identification and early referral to baby constraint, and then establishing the baby constraint programs. So how did we do this within a science framework? We used a knowledge implementation science framework called a knowledge to action cycle. And I don't have time, I won't go through all the details of the steps of the knowledge to action cycle, but there's 7 steps that can occur to help to facilitate, in this case, the integration of the Hammersmith into the neonatal follow-up programs, and then working to do the early referrals. And then we did a similar knowledge to action cycle for building the baby constraint programs at each of the sites. Of course, the 7 steps were different, but there was support to develop the baby constraint at each of the sites. So what we found as 2 really powerful implementation strategies was the development of virtual webinars. And we were able to do a lot of the training sessions virtually at very low cost. And that was really helpful. So supporting the knowledge transfer for the Hammersmith, supporting the knowledge transfer for how to run a baby constraint program for occupational therapists at the rehab centers. And this was facilitated through webinars and people's comfort, given the pandemic, in attending webinars. Now, we also found it really helpful to do community of practice meetings, and we met monthly, and all the sites got together, both the neonatal follow-up clinic staff and the baby CIMT leads, and we monitored questions, use, uptake of the baby constraint and the HINE. So these were two really useful strategies that, again, these monthly community of practice meetings were run over a Zoom meeting, and it made it very easy for people to meet. So where are we now with our knowledge implementation science project? We're a year into our Ontario-based project, and we now have 5 sites in Ontario that are offering baby constraint. And our next step is to start to facilitate rollout across Canada. And we have a grant application in, and a lot of interest in rolling out both the Hammersmith through neonatal follow-up programs across Canada, and then in partnership with the rehab centers, starting baby constraint programs across Canada. So let me finish the talk with a few practical comments on constraint therapy. So I'm going to give you a little bit of background on baby constraint, and then I'll comment on starting to move it into a preschool and a school-aged format. So Professor Anka Eliasson from the Karolinska Institute and team did an excellent randomized controlled trial that is published. And these are the main results. So they randomized children who had hemiplegic cerebral palsy or at high risk for hemiplegic cerebral palsy into receiving baby constraint or baby massage. And then they measured the affected hand score. And what they found is that children who received the baby constraint had improvements in their hand scores compared to children who received baby massage, who didn't change in terms of their hand scores. They introduced the program as a very much a play-based, parent-mediated program, and they did it in 2 6-week blocks. So here's the first 6-week block. Then there was a 6-week break, and then there was another 6-week block. And they asked the parent to play with the child for 30 minutes each day on a daily basis over 6 weeks, and take a little break, and then do another intense play-based treatment. And the parents were supported by an occupational therapist, but it was really the parent who mediated the program. So just some further comments on baby constraint. It's a very fun program. So the parent is playing with the child, and their hemiplegic limb is the focus of the intervention. And so the non-hemiplegic hand is gently restrained. And there's a variety of ways of restraining the hand. It could be with a sleeper, where the hand is just sewn shut on the material so that the hand is blocked. We don't recommend a rigid cast for a baby, and it's only for 30 minutes. And so then the non-hemiplegic hand is released. The other element that's very important is for the baby to be seated well, so that frees up their hand to play. And then the parent sits in front of the child to engage the child. And this is just a selection of activities that the parent is playing with the child for 30 minutes. Obviously, you need to pick a time when the child's not napping and is ready to play. Now, we recommend that a detailed hand assessment be done at baseline, because what you want the parent to be supported to do in playing with the child is to play at the just right activity level. And so doing something like the mini AHA or the infant hand assessment, you're able to see where the child is at. So these tools are hierarchical. So as the child progresses in their activities, they're able to develop different skills. And so if you have a child who is just starting to move their fingers, you're going to do different play activities than a child who is able to bury their grasp, depending on the toy that's being shown to them. So this is where the occupational therapist comes in to help to support the parent to do that just right play activity. And then also the reason that it's important to have some occupational therapy support to the parent through the baby constraint program, because the child's skill level will evolve. And so the play activities can evolve with the child. So I've given a little highlight on baby constraint, and I said at the beginning that I was going to put it into a bit of a developmental framework. So baby constraint is very much a parent-mediated program that happens with the child at home. Now, as we move to the preschool and school-age child, we can set about the program a little bit differently. So if we look at the school-age child, it would be very hard to do sort of a play-based program at home. It's hard to get a lot of home-based therapy for children at school age. And so what we have evolved to do for school age children is really to run constraint camps. And we often do it in the summer, so that if we're actively splinting and blocking their non-hemiplegic hand, that it's not done in school where they're needing that hand to take notes and things like that. So it evolves to a peer-supported constraint camp, usually over a two-week time frame, where they spend 6 to 7 hours a day, and the motor learning principles are built into the camp, where the just right motor practice is provided for the child, again within a fun play-based approach, and with usually 8 to 9 peers who also have hemiplegic cerebral palsy, and the children tend to quite enjoy the constraint camp. I highlight that if there's any occupational therapists listening today and they want further information, if you go to the Holland Blurby website, we do have a practical guide for implementing constraint therapy for preschool and school-age children available. So in summary, I've presented a vision for CP research driven through translational neuroscience networks with a powerful setting of common goals. I think really helps to move a system of research forward to make a difference to clinical practice more quickly. I've taking you through a deep dive of how we can look at underlying neural mechanisms of action, in this case, constraint therapy. And then talked about knowledge implementation science and how that can be a really effective strategy to also drive things into clinical practice. So I would just like to finish by recognizing many important people. So I'll start with my family here on the bottom. I'm blessed to have a lovely family and now have 4 grandchildren pictured here. I've been very privileged to lead our Division of Developmental Pediatrics at the Department of Pediatrics at the University of Toronto, situated at Hull and Bloorview over the last decade. And research is a team sport, and it's very important to acknowledge all the contributors to the research activities. So thank you very much.